but I'm glad to be here this afternoon to talk about this topic, which remains, I should say, obscure, because despite advances, there are still things which are not really understood in relation to what happens in this condition and how the body is affected. So I will share a few things that I have managed to put together, and hopefully we'll be able to have a discussion that can help us move forward. So that will be the outline of my presentation. And as a way of introduction, I thought I should say why we selected this topic. It has been pending for, I think, the whole of last year, because we think respiratory illness in children is common, chronic respiratory disease in children. And it seems to be, it's increasing, not seems, it's actually increasing worldwide, but more especially now in the developing world. And it's more marked in the younger children, those below 5 years. In some epidemiological studies, the rise has been reported to be up to about 1.5 times every 5 years. So this really becomes a problem if the children are getting more and more affected, and yet we don't seem to understand what is actually happening with them. And now the urban poor are more affected. As you know, like in our setting, if you have the problem and you are poor, a chronic problem, then it becomes difficult to manage it, as opposed to those who are better off having a similar problem. So we thought this is really something we should look at so that we can try to alleviate the suffering of these patients. Most of the chronic respiratory illness is due to allergy, and it causes a lot of agony both for the child and the parents, because the discomfort they go through doesn't remain with the child. If the child can't sleep at night, even the parents will be awake. And yet, if they are managed appropriately, the symptoms can be relieved. So I'll just go through some definitions. What do we mean when we say allergy? It means a hypersensitivity reaction that is mediated by immunological mechanisms, either antibody or cell-mediated. And this reaction comes about due to exposure to what we call an allergen, which is usually a protein substance that stimulates the immune system to react in a certain way. The problem is that in allergy, the reaction does not go the normal way, it goes the abnormal way. Some substances which are not proteins also participate as allergens, but for them to do this, they have to attach to other proteins, so they act as haptens. Now, sometimes we confuse atopy and allergy. Now, atopy is the personal or familial tendency to become sensitized, to be able to develop this allergic reaction. And this is when you're exposed to ordinary allergens. For example, all of us get exposed to the same things. Like in this room, we are breathing the same air, but some people may start sneezing while others are not. Those who will react are those who are already predisposed, those who are atopic. So atopy is like a subset within the allergic conditions. So there are allergens that have been documented. I won't really go through the names, but I wanted to put this here to show that most times the route of entry is actually where the problem starts, because the reaction starts locally and then it spreads as the body produces chemicals in response to the allergen. Like I said at the beginning, the etiology is not really, it's not clear. but a few things have been documented. Basically, it's to say that the body fails to react as expected, like it fails to develop tolerance to some of the things which should be harmless. And this failure of tolerance is usually genetically determined. Now, the way tolerance happens is a topic of discussion. People have put forward different hypotheses to try to explain why, for example, some people have symptoms when they are exposed to the same environment while others don't. And one of the hypotheses is what we call the oral tolerance. In this one, they consider three factors which interplay for the patient to become tolerant. And this starts early on, even from in utero. The gut is supposed to have normal certain flora which should interact with the microbial organisms in the environment, which act as antigens sometimes, and then there are other non-specific modulators, and the reaction between these three will either lead to tolerance or failure, depends on what is in the gut and the antigens that are presented. Now, though the interaction is within the gut, it is postulated that the tolerance does not only develop within the gut, but can also spread to the rest of the body. Meaning, you can ingest something, but the reaction will not be localized to the gut, but can also become systemic. Sometimes tolerance can be because of exposure to high doses of the allergen. This is just a diagram to illustrate what I've been saying. So the other theories that have come up are the hygiene hypothesis. I think we all know about this one, whereby some people have thought, if you look at the developed versus the less developed world, like our situation, previously the allergies tended to be higher in the developed world, and this was how they tried to explain it, that in the less hygienic environment, the patients or the children are exposed early to this, what would act as antigens, and because of their early exposure, they develop tolerance. But now we see that the allergic diseases are increasing even in our setting. So what has changed? So another theory comes in to say that there are counter-regulatory substances that are developed. Under normal circumstances, there should be a balance between the immune cells, the T helper cells 1 and 2. They should be in balance. But in allergy, there is a shift towards Th2 because there is failure of the Th1 to take root. In utero, the normal environment is the Th2. But now if the environment does not allow the body to react so that Th1 also comes up so that there is a balance, then you end up remaining on that lineage, and that leads to the allergies happening. Meanwhile, when we look at the poor hygiene, this side kind of explains the hygiene hypothesis. But then, and the explanation here is that when, despite the exposure, there are other cells which come into play called T regulator cells, which will now cause the balance between the two. Meanwhile, on the clean environment, those T regulator cells are missing. As a result, you don't get the balance between the two arms. So what will happen is that the individuals who are genetically predisposed plus the environment will now end up developing the allergic symptoms. So like I said, okay, the issues about allergy are not really fully understood up to now. but some chromosomes have been located. Some genes have been located on some chromosomes, and they also think that there is some polymorphism in codings that results in altered signaling, like instead of the reactions going the normal way, they are altered, and then the body reacts abnormally. And then the trigger is usually the interaction between the genetics and the environment. I say that the genetics are not yet fully understood because up to now, despite knowing some of these substances, still we cannot tell, even for people who have both those abnormalities, they don't react the same way. So more needs to be done to really understand why two people who seem to be carrying the same genes don't actually develop the same symptomatology. The immune system development starts early in utero, by 11th week of gestation. So the baby can be born when they are already leaning to one of the arms because of what the mother is exposed to. I have already said that the normal in vitro environment is the Th2 reactions, but maternal exposure can actually alter some of these reactions so that some children are actually born when they already have specific immunoglobulins to whatever they were already exposed in utero. But the expression will determine whether they are genetically predisposed to expressing or not. And then when they come out, whatever they are exposed to on the outside will also determine whether they will continue to have the Th2 reactions or they will balance and become normal. So the direction of response can be reversed actually. Now we'll talk about the pathophysiology. The main factor here we know is inflammation, which is the underlying mechanism for allergy. And like I have already said, there is alteration of balance between the Th1 and Th2 lymphocytes. Now, when it is leaning towards the Th2 response, then due to allergen exposure, then we have the inflammation, which can be intermittent or continuous depending on how much the exposure is. Now, atopy or the genetic predisposition promotes the Th2 response, which leads to IgE production. So this type 1 hypersensitivity is just a portion of what explains the allergy symptoms. There are other mechanisms, including the cells and other immune mechanisms. So there is an interaction between the environment and the genetic predisposition. Now, in the environment, there are things which will promote the inflammation, and there are factors which can be protective. Any imbalance will cause the symptoms, as I have already said. For example, on the left, those factors are listed as promoting airway inflammation. But you see, there are viral factors on the left and also on the right. So certain viral infections will promote inflammation. Like we know for allergy, viruses like RSV have been known to promote inflammation. Yet other viruses like hepatitis and measles on the right don't actually show similar behavior. But the bacteria and helminthic infections, bacterial bowel colonization, these are kind of factors which happen as postulated in the hygiene hypothesis, because if the environment is dirty, you tend to be exposed to all these things on the right, while the other side, the environment is supposed to be a clean environment, but these patients even if they were to be exposed, sometimes they don't have, they do not have, okay, they are protected against the exposure. And that can be contributed to by things like even just immunization. Now, and then in the middle, you have the genetic factors and the intrauterine environment where the child came from. The interaction of these factors will determine now whether the inflammation will happen or not. So in the pathophysiology, the first step is really exposure to the allergen, which will lead to sensitization. Meaning, the first time the patient is exposed, they don't really show any symptoms. But they will be sensitized, meaning they will keep memory of this antigen they were exposed to. It's now like an enemy, so that the next time they are exposed to it again, then it will be, they have to counter it, like to fight it off. And that's how now the process of inflammation becomes destructive. And there is the early phase when the antigen comes again, and then it's presented to the cells, and the cells produce IgE, which remains now in the body as antibodies. And the next time that happens, then you get inflammation. And depending on how frequent the exposure is or how persistent, then the process will really continue, as shown in this diagram. Ultimately, still depending on the exposure, this reaction may resolve or it will persist and lead to complications and maybe irreversible airway disease. So to differentiate acute and chronic, it's just about the duration and the elements that participate, and then the products that result from the reaction. We know that in acute phase, it just lasts a few minutes to days, and then most of the exudate is made of protein. There is vascular dilatation and exudation. You have a lot of secretions, and then the cells that predominate are mainly neutrophils. But when the process becomes chronic, then there are changes. The cells that participate are different. They become mainly macrophages and lymphocytes, because now the lymphocytes have to produce the cytokines, which really lead to the continuation of the inflammatory process. And then there will be changes in the blood vessels, still because of those processes. You may not see this, but from the chronic inflammation, there will be production of some chemical mediators that will now lead to other processes. Each of the mediator which is produced will follow a certain pathway which will produce other mediators that will result in the symptoms that we see. Now, the ones from the cells I've talked about can go into this pathway. I am showing this one because when we come to managing, we know that the process is inflammation, but sometimes there are other processes which happen which are not necessarily inflammation, and then you have to bring in other medications to manage them. Like at this level you have inflammation, but when you go to this side, the cyclooxygenase pathway, then you will have the leukotrienes ultimately produced, and those ones will not be, if you want to block their action, then the steroids will not work. That's why I wanted to show this diagram. So those chemicals which are produced in the alternative pathways still cause the same effects that happen in inflammation, like vasodilatation, increased vascular permeability, and then chemotaxis with the attraction of more and more cells. And the leukotrienes, as you see, cause bronchospasm, which is really an important symptom in respiratory disease. So we are talking about the airway, and I just wanted to say that in this, the airway is like a united, it's like one. You start from the nose up to the lungs. Whatever happens there is common to the whole pathway. The cells and mediators are the same, but the symptoms may not necessarily be the same. Because if it is the upper airway which is affected, the symptoms will be different from what happens if it is the lower airway affected. And yet the processes that occur are basically the same. And then I also wanted to highlight why we are concerned about the pediatric airway, because it's quite different from the adult airway, and when we are managing these patients, this has to be considered if we are to make them feel better. We know younger children are obligate nasal breathers. Now, if the nose is blocked, it's not like an adult who will think that now, okay, the nose is not working, let me open my mouth. Yeah? So they will start to struggle to breathe still through the nose when they could use the mouth. And then their airways, of course, are smaller. So if there is anything to reduce, like we are saying, inflammation, any swelling, secretions, and what will further reduce that, the size of their airways, and they will poorly tolerate the obstruction that will result. And then still there is marked compromise, because if it's already small, now if it swells, the reduction in size will be marked. The effect of that reduction will be more marked than in an adult airway, which is a little wider, and maybe if it swells maybe a third way, he still has some good diameter for access. And this has been demonstrated using this Postwell's law, whereby it shows that for an infant, say, who has an airway with a diameter of 4 millimeters, if the edema is just 1 millimeter, then the area will decrease by 75%, as opposed to an adult where the same thickness of edema will only reduce their cross-sectional area by 44%. But we are saying their airway is already big, so they might not even, at that rate, maybe they won't even feel the effect of the reduction in the airway size. So I thought after that I should go to just say a few things about how to diagnose allergy. It's a wide topic, but I hope we can get something out of this presentation. Generally speaking, allergy is diagnosed from, the first step is a detailed history and physical exam. And then you need to evaluate the patient's environment. We have said there is an interaction between the genes and the environment. So when the patient comes with the symptoms, you also need to confirm that the environment is actually contributing to what the patient is reporting. And then we need to identify the specific allergens, because in treating you need to reduce the exposure to this if possible, because that's the only way you will manage the symptoms. And then when we treat, we have to monitor whether our treatment is making any impact or not. I'll go through this one by one. The history, usually you look at the presenting symptoms. Since we are talking about the airway, I'm just looking at from the nose maybe up to the lungs. So what symptoms is the patient presenting with? If it is upper airway, you will have things like maybe nasal congestion or runny nose, sneezing, those kind of things. If it is lower airway, maybe there will be cough, chest tightness, and all such things. And then to confirm, because really we want to know whether it's an allergy, you need to get a personal history of atopy. We have already said that atopy is only a subsection of the allergic conditions. But it's good to know that this patient is atopic, because it will facilitate their management. Now, if they are atopic, for example, you want to know their geographical location. weather and the living environment, whether that location is contributing to the symptoms or not, because we know that some people can live in one place, maybe in Jinja, and they are fine, and then they move to Kampala and everything goes bad. And also we need to find out what their hobbies, sports are, and whether they have pets, because as you know, some of these things become like triggers of the symptoms. Their sleep patterns and the medications they are using. Because even drugs can, for people who are already predisposed, certain drugs can actually make them develop symptoms. On physical exam, usually we do a general exam, because for people who are allergic, you can see, but just by looking at their faces, you can see that this person may be allergic. There are things which are common, especially in children. I think in children. They look pale because most times their skin is also affected. Then they have what we call allergic faces. They have a typical appearance of the face whereby, for example, they have hyperpigmentation around the eyes, and then the creases just below the eye are very prominent. They may have, if you spend some time with them, they can demonstrate what we call an allergic salute. For children who have rhinitis, one of the symptoms is itching, so they keep scratching their nose, but they usually scratch it because it's not, they don't do it like consciously, so they develop a habit of just doing like this. So that is called an allergic salute. And then we need to check their weight, their growth, by looking at their height and weight, because this illness can cause growth retardation. So after the general exam, then you need to examine the target organs. The nose, the chest, those are usually the main ones, but also there is the skin, the eyes, and all that. And depending on where the problem is, you may go ahead to do other tests, like lung functions, or especially if there are lower respiratory problems. So after you've done the history and physical exam, you need to assess the environment. Assessing the environment, part of it will have come out from the history, but it's recommended that you actually visit where these patients, for children, we would say where they stay or where they go to school. If it is adults, maybe we would say where they work, because some of the triggers are actually in their living environment, and it will be useful for managing them. So when you visit their locations, you want to check for the common allergens, which tend to be perennial, that like the house dust mites and the indoor allergens, which tend to occur in old houses, maybe where there is a high humidity. We know that for those who have had interactions, either you have children or yourself, there are issues of carpets like this room. Some people might go out when their noses are already complaining, and then any upholstered furniture, things that can keep the house dust mites. And then in the environment, we look at whether there is pollen or molds around, if there are flowering trees or flowers around the house, that could be a problem. Now, after getting the history and probably coming to an impression that there may be atopy, then it needs to be confirmed, just to confirm that there is atopy. What is done is measurement of IgE. This is the main immunoglobulin that is mediator in allergic inflammation. Cord blood is used to measure the levels just when the baby is born. This will be able to tell you whether this patient is already predisposed. And then in younger children before 3 years, total IgE may be helpful. And then specific IgE screening test. The age below 3 is taken because After that, there are some other exposures, like in our setting. I know now it's not very common, but helmintic infestation is one of the causes of raised IgE. So if it is done in older children, it may read high, not because of atopy, but because of other exposures. So if you confirm that the patient is atopic, then you need to identify what they are allergic to. Now, the testing should be guided by the history, the clinical exam, the environment of the patient, and then the results of some of the specific tests done in screening. Blanket testing is not recommended because you can react to many things when they actually don't cause any problem to you. What we are worried about are the symptoms, not being sensitized. If you don't develop any symptom, that's not a big deal. But if you develop symptoms, that's what we would want to manage. So the blanket testing is not good because surely, most likely, some positive tests will come out. And then what do you do? If I drink milk and I don't have any problem, then I go testing and the reaction comes out very positive. What will you do? For me as a patient who knows that I have no problem with milk, I may just not take you seriously, the doctor. So the test should be done in a targeted way so that if it is suspected that maybe this patient reacts to egg, and then you test and it's positive, it's easy to explain that, you see, it's true, the reason why you're getting these symptoms is because you actually are sensitive to the egg. So there are also other in vivo. The test can be in vivo, like the skin prick tests, which are commonly done, though not in our setting. In our setting, it is still under research settings only, but in other settings, it's a usual test. It's easy, it's rapid, you get results within a few minutes, less than 30 minutes. It's not very expensive, and then you can decide according to the results. And then the in vitro, where you take off samples to look at the immunoglobulins and mainly immunoglobulins. Then, after you have made your diagnosis, usually what happens is that the patient is initiated on treatment, and then you need to monitor how the patient is responding to the treatment. Most times we do it clinically, but it's recommended that some tests are done. Total blood eosinophil count is easy, we can do it in our setting. If you know that the first time you saw this patient, maybe the count was 1,000 cells, they are on treatment, and after maybe 2 months, you'd repeat the count, and it's probably maybe 800, then you know you're making progress. At least it can be a monitoring tool. Now for those with nasal symptoms, the smear can be done and the nasal eosinophils counted. They also reduce on treatment. And then there is in inflammation, some of the cells produce this substance called nitric oxide, especially in asthma. So its levels can be measured in the air that is exhaled, and there are normal levels, and you can tell when the levels are decreasing that the patient is responding to treatment. And then there are other things which I think are beyond our reach. Probably number 6 may be done under research settings here, but it's supposed to be a usual test for these patients. Now, in managing allergies, I thought I would just go through the general management, and really the first factor to control is the environment. We have said the main actor is an allergen, so if possible we need to avoid or reduce exposure to the allergen, and then we treat if the symptoms are still there after trying to reduce the exposure to the allergen. And treatment is done to it is targeted to the different mediators. Like I showed you in the other picture, there are different mediators, and the way they are produced, the mechanisms by which they are produced are also different. So you will use their effect. The mechanisms of production and their effects are different. So when you're treating, you can do one of many things. One, you can stop their production. You can reduce their effect. Yeah, mainly that. So we use anti-inflammatories to reduce the effects of inflammation. Then there are some substances called receptor-mediator antagonists, like anti-leukotrienes. Mast cells are the ones which, when the body is re-exposed to the allergen, the mast cells degranulate. So they can be stabilized so that even when they get in touch with the allergen, they don't degranulate. Cromolyn, but it used to be very popular many years ago, but it's not so popular now, especially here. And then you can use immunomodulators, like substances against immunoglobulin E, or do what is called immunotherapy. Then other treatments are according to the site that is affected. That is just the same information in that way, because these are what happens. You have the allergen, you have a process where IG is produced, and then that is the actor that leads to most of the other cells producing the mediators that will ultimately lead to the production of the symptoms. I don't know whether I should give a break here. I think I have talked for too long. Because, how long is? Well, maybe 20 minutes. I thought I would go briefly through the two main diseases of the airway. I picked allergic rhinitis and then asthma, but not in a serious way, really.
What does the house feel?
Okay. So I thought I'd look at allergic rhinitis just to bring into perspective what we have discussed, so that we see how the upper and the lower airways are affected and how we could possibly help. So now this is inflammation of the mucous membranes in the nose, throat, sinuses, and ear passages. It's not just the nose. When we say rhinitis, even the surrounding organs are involved. And because it's allergic, it means it's a response to an allergen. The reaction may be seasonal or perennial, depending on what allergen it is. And up to 40% of allergic rhinitis is associated with asthma. And in children, it is said to be more common in boys than girls. Symptoms: there is nasal congestion or stuffiness and itchy nose. The congestion is usually common in the younger infants. There is no mucus coming out, but really the nose is blocked because of the edema that is happening following inflammation. And then there will be sneezing. There will be nasal discharge, which is usually clear. Now, adjacent organs are also affected, especially the ears, the eyes, and the roof of the mouth. Now, the eyes usually change color. They become kind of red and teary. The roof of the mouth, if you have been with, or for people who have these issues, they know what they do when the roof of the mouth itches. Yeah, that. Now, the chronic symptoms are not usually observed in younger children because they need time for sensitization before they start having the chronic reactions. Now, allergic rhinitis is not taken seriously, but it has a big impact on the quality of life. Because of the symptoms, the patients suffer a lot. The nose is blocked, they can't breathe, there is itching all around, you can't scratch. You can't scratch inside your nose or ears. Okay, maybe the ears you can, but in the mouth you cannot put there anything. So you try to make that clicking sound. So it's very uncomfortable. But because people don't see anything outwardly about the suffering, it is not taken seriously. But actually, allergic rhinitis is said to impair the quality of life more than asthma. Because asthma, you get cough and everyone wants to get treatment and get rid of it. And maybe you get an attack and you run to hospital. But in nasal congestion, you just stay with it. Now, and they don't sleep well. So for children, even adults, if they don't sleep well, then the day cannot be okay. They will not study well. In fact, they say the morning hours for children who have allergic rhinitis are not the best time to study things which need you to be alert, like math. So they will fail. They won't do well if the lessons are put in the morning, because they are still trying. They haven't really, woken up or something, but they cannot be alert. So their concentration is affected. And then, of course, either they'll end up missing school or actually being there, but it's like they are not there since they are not alert. And there is a financial strain. The medication used may also impair the quality of life. We know the drugs we use to relieve symptoms, mainly the antihistamines, can be sedating. So you go to bed trying to relieve symptoms, you wake up still feeling sleepy. So it is something really to take seriously. The diagnosis, like I have said, it still depends on history. I think I won't go through everything, but we need to take the history of the symptoms to characterize the symptoms, and then we need to examine. Maybe I'll dwell a bit more on the examination. Because if it is allergy, like I have said, they will have a typical appearance, especially around the eyes and the nose. You may have that crease because of the allergic salute. And then within the nose, there will be changes. You will look at the character of the secretions. We have said for allergic rhinitis, it should be clear. But they may develop some abnormalities within the nasal cavity. And one of them is hypertrophy of the turbinates. The turbinates we easily see are the inferior ones, but also the middle ones can actually enlarge and kind of protrude into the cavity sometimes. So this is just to show what I'm talking about, what I was saying. You see the darkening, these are white pictures, but you can see the darkening around the eyes, the allergic salute. Because of that, they develop a crease at the base there of the nose. Now when the turbinates enlarge, you see there should be at least half of the cavity should be open. But when the turbinates enlarge, then the space is reduced, and actually this turbinate can grow and touch the septum. The nose can completely be blocked. Now for children, like I told you, who don't know that they can actually open their mouth to breathe, they may continue to struggle to use their nose, which is blocked, when it's not helpful. Then we also look inside the mouth, because when the glands are enlarged, we said the allergic rhinitis involves the nose, the throat, the ears, and the eyes. The tonsils become big, and the back of the throat changes the appearance to develop something called cobblestoning. And sometimes when these glands are so big, then the children can develop obstructive sleep apnea. And because we've said it's one airway, when the upper airway is affected, the lower one may also be affected. So you also look for other symptoms. that may be suggestive of asthma. And we said most up to 40% of patients with allergic rhinitis have asthma. So comorbidity can be quite high. This is cobblestonic. When you look at the back should be smooth. The oropharynx should be smooth. But in these patients, you'll see that kind of appearance, like cobblestones. So you have to differentiate it from other conditions. There are other types of rhinitis which are not necessarily allergic, but these are not common in children. So I will skip it. But maybe the challenge sometimes is to know whether it is just a cold or it is actually allergic rhinitis. I've had mothers, children can come for another reason, to the doctor for another reason, and the nose complaints will not be part of the problem when actually they are a problem. Because like I said, when we are assessing the quality of life, people don't take it seriously, but it actually causes a lot of discomfort. So we need to differentiate the usual cold from allergic rhinitis. The main way is really is the duration. A common cold does not last. Most times it's done within 1 week. But in allergy, it's like the flu. The mother will say, this one's flu doesn't go, it's not a problem. It's okay. That's how he is or she is. But it needs to be managed. Then the mucus is clear. It's like water. It's watery actually. And it doesn't cause, when you have flu and it has taken long, the children usually can develop wounds around the nose. But this one, because it's not irritating, though they have symptoms continuously, you don't usually find them with sores around the nose because it's just a clear watery discharge. And there is itching. They may keep rubbing their nose to try to relieve that. And if not managed adequately, you can develop complications. These systems which are connected, the organs which are connected to the nose can actually develop issues because of allergic rhinitis. If you have the turbinates obstructing the nasal cavity, the drainage will be impaired, like from the sinuses and there can be blockage of those channels, and that can lead to infection subsequently. And then you get impaired senses. They can't smell, they can't feel the taste of the food. Treatment, there are guidelines that have been developed by allergic rhinitis and its impact on asthma management group. So this you can always get from a book. But basically, we use medications that target the different cytokines which are produced during the inflammation. Like we use antihistamines, we use the steroids, the chromones. I highlighted that decongestants because we don't use them a lot in children. They have a rebound effect. They say if you have to use them, then not more than 3 days. And then the antileukotrienes. I just have a few slides on asthma. We know it's an inflammatory disease characterized by recurrent or persistent episodes of this condition. Symptoms: cough is the main one, wheeze, breathlessness, or chest tightness, especially at night or morning. The common presenting complaint is cough, which is not going. Children cough for months. During the day they are fine, then at night it's a problem. So when you get such patients, think about the possibility of asthma. Most of the patients develop symptoms by 3 years of age. 60%. But not all of them will continue with the symptoms. Only 60% will. No, I beg your pardon. I've said majority of the wheezing, these children who wheeze, most of them wheeze. They start wheezing early, but not all of them will necessarily have asthma. Less than a half of them will actually continue to wheeze. And the likelihood of them continuing to wheeze depends on the risk factors. Their genetic susceptibility and the environment. So there are those who are called transient wheezers, and the common term used now is viral-induced wheeze. They get like a cold and then they wheeze. But those symptoms will not last long. Usually by 5 years they have resolved. They start quite early in infancy. Some start as early as 3 months of age, and they don't have any history of atopy. And the problem usually is that their lungs are a bit small. Then the persistent wheezers are the ones I would call those who have allergic asthma. These ones will, because they have the atopic background, they will continue to wheeze. We are saying the atopy, you can't, once you're genetically predisposed, you can't change that. You can only change the environment. So if they start wheezing in an environment, then they will continue to wheeze. So it means usually they will have raised IgE levels, they will have positive skin prick tests, and feature suggestive of bronchial hyperresponsiveness and all those changes that happen with asthma. I think I don't have to repeat the pathophysiology. I'll just talk a bit about diagnosis. Even here, it is mainly clinical, especially in younger children. We depend on the history, not much on examination, except if they are having an episode. Otherwise, we just use clinical diagnosis. In older children, we may be able to do some tests to confirm that they have reversible airway obstruction, or the other way to make a diagnosis is to use what we call the asthma predictive index, which details you can get from reference books. But I will mention, when you're seeing these patients, especially the younger children, people think that you can't make a diagnosis of asthma in young children, but you can actually make a diagnosis even in a child less than 6 months if they have some of this. Frequent wheeze, more than once a month. If somebody starts at 1, maybe 3 months, and by 7 they have had 8 episodes, and they have a family history. Family history, there is something that seems to trigger these episodes, and then when they get like a cold, it seems to last forever. That's what they call, it starts from the nose and then they end up having cough, and then it takes longer than 10 days. That is what is referred to as a cold going to the chest. And then when they are treated, they respond to a bronchodilator, or sometimes we want to test, we want to prove that actually this is an allergic condition. We give a trial of steroid treatment. Short course, 10 days of oral steroids, and then they may have other allergic conditions like rhinitis, eczema, or food allergy. So if you have such features in one child, even if they are 7 months, it can be asthma. Of course, there are differential diagnoses. You need to rule out other things, not just because the patient is wheezing, you start to treat, especially the acute episodes. I have had these experiences where I have been called because the patient has been nebulized many times and is not responding. But it's not asthma, and it's not a wheeze maybe. It could be It could be what? It could be a stridor. Yes, not every sound that you hear from the airway is a wheeze. Okay, treatment. Really for asthma, the goal of treatment is to enable the child live a normal life. Normal life means they can sleep well, they can go to school and play like any other child without any hindrance. And their principles: early diagnosis and assessment of severity so that you can start the appropriate medicine. Drugs alone don't work. You have to control the environment. We have said it is genetic predisposition with environment interaction. So this needs to be controlled where possible, but sometimes you may not be able to control, especially if you haven't even identified what the trigger is. Then we use the medicines to achieve control of the symptoms so that the patient can be comfortable, and we continue to follow up. I have talked a lot, but I think what comes out is really that this thing we are calling allergy is a process. It's a continuum whereby the patient is sensitized and they develop with a leaning towards the Th2 response. And then after sensitization, they will be prone to having airway inflammation, which may be acute, but it becomes a problem when it is chronic. And most times it's chronic because of the triggers which tend to be present all the time. The airway is one, so treating one part may affect the other. And allergic disease greatly impacts on the quality of life. So we should make every effort to relieve the symptoms so that the parent and the patient can be happy and the doctor can also be contented. Thank you.